On to our next slide here with our panelists. So first, I'd like to introduce Dr. Anna Nordvig. Dr. Nordvig specializes in cognitive disorders of the brain. She is a board-certified neurologist at New York Presbyterian Weill Cornell Memory Disorders Program. She completed a fellowship in behavioral neurology and neuropsychiatry in the Division of Aging and Dementia at the Neurological Institute at Columbia University Medical Center. There, she also completed her medicine internship and neurology residency. Dr. Nordvig decided to study medicine after a career in business. She felt a calling to care for patients and to investigate the mysteries of the aging brain through research inspired by her patients' questions. Also, we have Dr. Allison McLahone, who specializes in geriatric medicine, and she takes a special interest in dementia evaluation and management, medication management, and palliative and hospice care. Dr. McLahone earned her medical degree from the State University of New York Downstate College of Medicine. She completed medical school summa cum laude and with research commendations. Afterwards, she completed an internal medicine residency at Stony Brook Hospital and performed a geriatric medicine fellowship there as well. In evaluating and treating her older patients, Dr. McLahone understands the impact of social factors, mood and cognitive disorders, chronic pain and functional impairment on quality of life and healthcare utilization. Her individualized approach that addresses these issues, together with treatment of the patient's chronic medical conditions, results in improved outcomes and quality of life. And then also joining us tonight is Dr. Donald Price. Dr. Price is a fellowship-trained board-certified neurologist with an interest in general and diagnostic neurology. He has been in practice for 33 years and was previously in practice at East Carolina School of Medicine in Greenville, North Carolina. He is the director of neurology at Stanford Health. Dr. Price has extensive experience in stroke, general neurology, dizziness, and neuropathology. He is trained and practiced as an inpatient and outpatient neurologist. So thank you all so much to the panelists for being here tonight and participating in this discussion on advances in dementia research. And then moderating the discussion tonight is Dr. Peter Hassapis. Dr. Hassapis, some of you may know, he is a local physician in New Canaan, an internist with New Canaan Medical. And Dr. Hassapis is also the medical advisor to the Navigator program. So thank you all so much for being here. And Dr. Hassapis, I will pass this along to you to get started.
All right. Good evening, everybody. Thanks so much for coming. I'm Peter Hassapis. Welcome. It's been great to have these sort of, ongoing, I think like once or twice a year we do, I think it's like once a year we do a panel discussion, but also, being able to give talks to the community so that people sort of understand more about Alzheimer's disease and, how to recognize it and what avenues you may have to sort of pursue it in terms of, treatment and diagnosis. I guess tonight what we're going to try to take a look at is sort of some of the other factors that might be associated with Alzheimer's disease and with dementia, and, like sort of what different factors are contributing to to increased diagnosis, I guess, I'm not even sure if there's an increased diagnosis, but what sort of factors are driving, more cases and what we can sort of do to intervene. And we'll probably, hopefully get to some newer research and studies on, prevention and treatment therein. So I guess one of the things here that, that we talk about are sort of, what are factors that are, maybe contributing to this beyond just an aging population? Are there other things that are contributing to sort of a growing risk of dementia? And, are there social or environmental factors that are at play beyond sort of the usual things we look at? What do you, and I don't know who wants to.
When we got a bunch of questions here, and I was intimidated by all these questions. I was like, oh my God, I have got to do a lot of research in a week. So I started looking up a bunch of articles, but I remembered one from our American Academy of Neurology conference, which was this one, Dementia Prevention, Intervention, and Care 2024 report, Lancet Standing Commission. And I made a copy of the diagram, and I put it in all you guys' chairs here, so you can look at that. But but it just shows risk through early life, but basically shows early life, midlife, and late life, and how they contribute to risk of subsequent development of dementia. Terrific diagram, I think, and I've shown it to a bunch of patients. So you can see early life, it's less education. Midlife, they've listed here, and the percentage by increase the risk, and if it's modifiable. So midlife, hearing loss, high LDL cholesterol, depression, traumatic brain injury, physical inactivity, diabetes, smoking, hypertension, obesity, and excessive alcohol. So that's midlife, and that's defined as 18 to 65. And then after 65, late life, social isolation, air pollution, and visual loss. So these are all 45% potentially modifiable. Now, when you actually try to dig into these a little bit, I think it's really difficult because a lot of it is they're epidemiologic studies, they're metadata, and so you're really separated from the actual studies and data. And so it's very hard to look at it objectively. You read an article like this, and every sentence seems to contradict itself. And so it's really hard to look at it objectively. I've historically, I've taken care of all types of patients with neurologic disease, but dementia patients, historically for me, it's always been patients come in, they have no other past medical history. They've never had a heart attack, they've never had liver disease. They come in and there's a subtle cognitive decline that starts to happen. And it's really the absence of other comorbidities that I always thought, they've survived cancer. They've survived, or they've somehow eluded cancer or coronary artery disease, and they've made it into the time when you're most susceptible to degenerative diseases. So that for me, so reading an article like this and thinking about all these other contributors, it seemed kind of counterintuitive actually reading the article. So anyhow, that's just to address the risks over a lifetime trajectory.
Yeah, I would say this is a fantastic chart that covers a lot of bases. I, as a geriatrician, feel that it is rare that I get a patient who has no prior medical stuff. I mean, a lot of times I will have patients that have comorbid diabetes, comorbid high blood pressure, history of stroke, history of head trauma or brain bleed. I mean, I feel like it's the works. So I see these risk factors, and then I see also those metabolic and cardiovascular risk factors as well.
Okay.
Well, one other thing I'd say is, so we represent we're coming from different areas, right? So I see a general neurology population. I see people with vascular cognitive impairment, or I might see someone with a movement disorder as their primary thing, but then I realize there's a dementia that's brewing in the background, and to see patients with all kinds of other medical issues. And
it's very complicated, and I feel like a lot of dementias are mixed. It's a mixed bag, and I think it's not terribly common that we see a pure Alzheimer's. I mean, even the risk factors for Alzheimer's are cardiovascular. So I feel like there's a lot of things that we still don't know about these, dementias, which is the umbrella term, and then the different types of dementias.
I come from a little bit of a different background. Hearing me is the most important part. We go through this in my office before we do anything else. May I just ask for the audience to show me, I don't want any personal information, but how many of you are here because either yourself, someone in your family, someone you know or care for or know as an acquaintance is suffering from some memory loss and you just want to learn more about it? Okay, so pretty much everybody. How many of you are just here because you're curious in this topic? You want to help your own health and the health of others? So, and that's what we see in our clinic as well, is at Weill Cornell, where I practice, we're actually quite lucky because we get to really limit the patient's questions from why are they here. People only come to us with either a history of memory loss or some kind of cognitive dysfunction, or maybe a family. They're worried about it to some degree, whereas I think that my colleagues here have a much harder job because they have to decide who actually should be referred and who are their level of care or not. So from one perspective, when you go to see your primary medical doctor or your geriatrician, that's always your first stop, and you're going to be hearing at every annual physical about all these modifiable risk factors. Well, research chart, we've looked at this one, we have many diagrams, but I love the way this is organized and how it tells you about all the modifiable risks. I would also add sleep apnea as another one, or just interrupted sleep, some kind of sleep disturbances, urinating during sleep. But there are so many others that over the course of the lifetime we probably haven't even discovered yet. We do think that to some extent, progressive conditions that cause dementia, which are different from some other conditions which may cause a lot of cognitive issues but don't progress, we think that the progressive ones probably all have at least some genetic component, and a lot of it we haven't figured out. But first of all, take this home and stick it on your fridge. Second is surround yourself with people who care about these things and who are willing to encourage you. We were asked to look up a number of things. So there's one trial called the Pointer trial, which was actually really on patients who didn't have any memory loss. So you could not have had any problems with your cognition to even be in the trial. And there, they gave some really monitored interventions with like over 38 visits, in the intervention arm, someone almost like a personal coach to keep you on track with all of your weekly, monthly needs for your physical health. We always say there's this story that there's a blood-brain barrier, and that what you do to your body, you have a nice wall up between that and the brain, so you're protected and you're okay. And that's not really true. The blood-brain barrier exists, but it's very permeable, very much affected by all the things that happen to your body. And of course, you also have your blood vessels, which exist in your brain as well. So treat your body well and know that that's also helping your health. Now, sometimes you have the unlucky patient, they've done everything well, and they're playing tennis still, and they're in their 80s, and now they're developing memory loss. But my answer to that is maybe if they hadn't been treating their bodies so well, this would have developed earlier.
Yeah, I mean, I find in primary care, what I find a lot is I have a lot of, I do have a fair number of patients who present, with dementia. And so we're looking at all these risk factors, and very often, as I say all the time, it's really brought to attention usually by a family member. So having people around you who care and who can notice these things and pick up on these things is really helpful. But yeah, I also love this chart because one of the things that I tell people all the time is pretty much along the lines of, well, all the things that are good for your heart are also good for your brain. And that kind of, really holds true, basically. If you look at all these, the big risk factors for coronary disease are, high LDL cholesterol, physical inactivity is not a big one, but it is, diabetes, smoking, hypertension, obesity. All those things are kind of, major cardiovascular risks. And if you can kind of take a lot of those off the table, then, you're probably doing yourself a favor, because I think there probably is a ton of overlap, in terms of the two biggest, I think the two biggest sort of classifications of dementia are Alzheimer's type, or, degenerative type, and vascular. And there's got to be a lot of overlap between those. So I think that if what I try to tell people, because obviously this is something that, because we're getting places, but we're not awesome at treating this, or reversing it, or, slowing it, the best thing is to try to prevent it. So, and these aren't like guarantees, but this is what I tell people, and alcohol, I wonder if that's even a low number. I don't know. I definitely have a significant number of people who present to me, at an age younger than where you would think they would start developing cognitive decline. And it sort of comes out, well, actually, doc, he's been telling you he has 1 or 2 drinks a day. He really has like 6, so it's stuff like that. But there's definitely a lot that you can.
That's probably not Alzheimer's disease. That's alcohol-related cognitive impairment.
Right. Okay.
Wernicke-Korsakoff. Yeah. So dementia is a syndrome, right? And there's specific diagnoses, right? So there's a lot of things that can present as dementia. It can be HIV. It can be alcohol-related. It can be vascular cognitive impairment. But Alzheimer's disease is a subtype, specific diagnosis. I think you also brought up an interesting thing. Dementia patients almost never present themselves with memory problems. They don't come in saying, I'm having a memory problem. It's usually the family members notice, drive the wrong way on a road, that something happens.
Yeah.
So there's some sentinel event that then drives. And so I know, I've walked into hundreds of these rooms, and I know when there's multiple family members present, and one person sitting near the door, I'm probably about to see a person with, because that corroborative information is essential. And again, the patient often seems blissfully unaware of the symptoms that have gradually developed over the previous year.
Can I just say something before we,
Yeah.
I love this chart, and I wish I would have made copies for you, and I'm so sorry I didn't, but there is a tool that I came across in looking at more of the preventive side, because I get this question a lot, not necessarily from the patients that I see, but from the family members, like how can I lower my chances of getting dementia, Alzheimer's. And there's something that I tell people to go take a test. It's called the Brain Care Score, and I've actually taken it myself. So, but it gives you it goes over all of these modifiable risk factors, including the cardiovascular risk factors and these other risk factors that we were talking about from the article, and it. You get a concrete score, and you kind of can get an idea of what things you need to work on to lower your risk of dementia in the future. So I would encourage people to take a look at this. You can just Google Brain Care Score, and it's something that I would encourage people to talk to their doctors about, not just make a change based on your score, but actually bring it to your doctor and talk about things and how to make changes.
Yeah, I mean, absolutely, that totally makes sense. So I kind of glossed over this and said, well, yeah, what protects your heart, protects your brain. But do you, is your experience that it is really just an overlap with vascular issues, or are there other ways where, having high fluctuating blood glucose or, dyslipidemia or, hypertension, I think it's clear probably is just through ischemia. But are there other ways in which those things actually have an impact that could be explained?
So I'll take this moment to kind of distinguish, to tell you what I tell patients. There's a continuum. So if you don't have any concerns at all about your own cognition, and that includes your memory, your executive function, planning, prioritizing, organizing, figuring out how to use tools and fix things in the house or do chores, and your language and your ability to get places, if you have no concerns about that, and maybe you do or you don't have a family history, you would be called a normal control. And if you had maybe a little forgetfulness here or there that didn't impact you at all, you'd probably still be called normal for age. That's how, that's what would show up in your chart. And I think the answer to your question is different for a person like that, and that would be going with this chart. It would be increasing your physical activity to 150 minutes a week plus 2 times a week weight-bearing exercise, which is a lot more than most of us do. When I started researching this stuff, I had to make some serious changes in my own life. Like hypocrite in clinic there. Decreasing your alcohol, in Canada, the official recommendation is 2 drinks a week. Here it's been, I think, 7 for women and 14 for men, and we have much stronger lobbies here. So I tell patients that all the time, you got to listen to the Canadians on this matter. They've read the research. Alcohol is a direct neurodegenerative substance. The blood thinning effect that red wine has, to some extent, maybe has some good antioxidants, but you can get that from other foods. Then the sleep, so protecting your sleep, not letting your sleep go interrupted throughout many years. Not missing a diagnosis of sleep apnea. I will tell you, almost half the time I'm sending home sleep studies on patients because something comes out, a little history of snoring, even gasping for air. People are waking up many times a night to go to the bathroom. Guess what? That could actually mean you have sleep apnea, not just an overactive bladder. So getting that checked out, as annoying as it may be, as annoying as the treatment may be, that's associated with a lower risk of all-time dementia throughout life, and all of these other factors. The hearing, the vision, especially the hearing, the ability to take in a lot of information is important, the ability to stay active. We know that patients who have a high level of cognitive reserve, which I bet includes every single person in this room, that you're taking a Thursday night beautiful evening to sit in a library and listen to a talk about how to improve your memory, right? People with a high cognitive reserve in the studies, they still may get dementia, but it will happen later in life. And the tricky bit is when it happens, that person has been compensating for such a long time because you've been finding workarounds and things that it may seem like a more precipitous drop off at the time, like people might get shocked, it might not be as slow, but it's because that person has been hiding it, working around it, finding ways to compensate because they have more cognitive faculties. So from a young age, just staying very mentally and physically active is great. There have been studies that ping pong is a fantastic sport you can play your whole life. For example, some of these sports that tennis, if your joints can handle it, mine can't. So there are many things even without any cognitive issues at all. And then once you start to get into the next step, which is we call subjective cognitive impairment or decline, you might see this in someone's chart, a loved one or your own. And that means the patient is saying, or someone's saying, yes, there's some difficulty, but your tests aren't picking anything up. And then you might some of those people will progress to mild cognitive impairment, big diagnosis that covers so many things that people are, to give out a lot. And only some of those people will progress to actually having dementia. Dementia means you no longer can do things for yourself in a meaningful way so that you could live alone and function alone. So it takes a lot to get to dementia. You can have mild cognitive impairment for many years. And for many people, the goal is to stay in that mild cognitive impairment stage as long as possible. In our clinic, different from geriatricians and even general neurologists, we try to keep people from progressing even further with even maybe some different techniques. For example, many studies have shown that mood disorders either worsen significantly or present anew in 60s, 70s, later in life. When they present later in life, they're often masked by alcohol, because that is a really good way to chill out and relax for the day. And sometimes, that evening drink happens a lot earlier than we want to admit, right? But it's a way that people self-treat new anxiety, depression, but it's a brain toxin. So I say, if you're having depression, anxiety, figure out ways to treat it. Speak with your GP, speak with a psychologist, speak with a psychiatrist. One, because your anxiety center, your fear center, the amygdala, is like a chewed up piece of gum that's stuck to another chewed up piece of gum that's your hypothalamus, which is your memory center. They're right there next to each other behind your ear. So you can imagine if your memory is having some difficulty, there are some neurons that are not so functional, it's very likely that someone's doing well. Some team is doing well.
Someone like that comment.
So get that treated, okay? Because it's likely going to help release the handcuffs on your memory if you can keep your anxiety, for example, your depression in control. Sometimes anxiety and depression causes what looks like a dementia. So that's another reversible factor. It's separate from the vascular risk factors. You might see this in yourself, your loved ones, your friends. It doesn't always have to be a progressive memory condition. If you lose a loved one, then you fall into that and it lasts more than a few months. Seek care, because it not only will improve your mood, it may actually improve your memory and your other cognitive functions. And then I'll end this part. In terms of modifiable, a lot of times we go through the motions, we check the boxes, here are all the things I'm supposed to do. I find that when people they rediscover the hobbies they used to have, that they used to love, that they spend time with people that they love, that there is actually a serotonin surge, a dopamine surge in your brain from doing things that you love to do. And that can take the place of many of the medications that we actually offer to try to activate and motivate people's brains so that they can stay more alert and remember and be more cognizant. So trying to build in hobbies and social activities that actually give you pleasure can be brain protective.
Or get a big orange fluffy cat that you're not allergic to, yeah.
I want to ask something to the panel real quick, just to see what you guys think. I mean, the things we're talking about, exercise and social engagement, those are over a lifetime trajectory, and people are often coming after the age of 65. So do you think these are still modifiable? Because you can see from this chart, really, these are midlife modifiable factors, whereas in late life, if you start all these activities when you're 70, to what degree are you going to help to, rest the progression of your cognitive impairment?
Depending on the reason for your mild cognitive impairment, absolutely you can slow it down or arrest it. I'll give a few common examples. So if your memory decline, cognitive decline, is due to vascular disease, whether it be ischemic strokes or bleeding strokes or what's called microvascular disease, the smallest blood vessels get all gummed up and your brain gets a little bit inflamed, but no one's willing to call it a stroke. By controlling your blood pressure, your cholesterol, stopping smoking, switching to a mind diet, and increasing your exercise, you can actually arrest the progression of that microvascular disease and prevent strokes to some or a large extent. And the fewer of those little spots you have in your brain, the more functioning brain tissue there is, the slower it's going to progress. And that's not just cognition, that's also balance and motor function. That's one easy example. Stopping drinking. So people, not only do they have worse daytime functioning, if you're drinking alcohol, then you're waking yourself up at night. So actually, you sleep more poorly when you drink, and you often wake up in the middle of the night from it. So you're harming yourself day and night from it. And you actually, there have been studies where you decrease your brain atrophy by significant percentage points just by stopping drinking, even for 6 months or 1 year or 2 years. We also do see it in our patients who have been diagnosed with Alzheimer's, frontotemporal disease, Lewy body disease, all the different types of progressive conditions that cause neurodegeneration and therefore dementia. When people drink and do these bad things to their bodies and brains, they just function worse every day and seem to decline faster. And also, like, preventing, I hate saying this because how do you do it, but preventing unnecessary infections is a big one. And I feel like the scientific community has a hard time with advising people on how to do that, so we don't talk about it as much. We saw a huge uptick in people presenting with some cognitive issues after the COVID pandemic hit. I see patients still all the time who they got a lot worse cognitively after COVID, and oftentimes they heal, and other times it was the beginning of their disease. Lifetime infections, while to some extent they strengthen you, on the other hand, there's no reason that you need to let a pneumonia fester. And if you have any symptoms, get that UTI treated, inflammatory diseases, other infections, get them treated faster, because those small inflammatory molecules, they do cross the blood-brain barrier and they activate your brain. And there are many studies now showing that more infections can contribute to developing things you might be predisposed to earlier.
And everybody that I see so most of my patients that come in are for memory. I would say probably about 75%. Always part of my discussion with them is on the importance of these lifestyle measures to support brain health. And I think, and so I really stress that. And actually, up until only a couple years ago, I mean, we really didn't have anything, in clinical practice to use to slow the disease process, particularly for Alzheimer's. So the lifestyle measures that I talk about are very similar, and they address these very, these risk factors. So, it is the exercise, it is the what we can do to improve sleep. It's, eating, a diet that is rich in fruits and vegetables and omega-3s. And it is challenging yourself cognitively. And whether that's, that can be, I tell people to do things outside of their comfort zone. So, if they're not used to doing crossword puzzles and they have an aversion to that, I say that's the perfect activity to do. or, joining a book club or there's definitely apps on, on your iPhone or your iPad that you can do. But there are things that I think we do in tandem with the treatments that we prescribe that you guys can do and that are helpful and meaningful. And some of the studies that we were talking to are in older adults, maybe not with cognitive impairment, but do show that even in later part of life, that these, treating these modifiable risk factors can have significant benefit on cognitive function.
Just something that I've always sort of wondered is this link between hearing loss and cognitive decline. And is the understanding of that, so as primary care docs, should we be having everyone test their hearing, and if you're losing your hearing, get hearing aids because that'll prevent dementia? Or is it a marker for dementia? And so whether you're intervening on that because maybe somebody has some hearing loss, but they don't really clinically notice it, or is it more the case where people have hearing loss and so they become more socially isolated and disengaged? If there is one, I don't know.
Yeah, I had to read a couple of studies on this, like last year for a comment. It's mainly the lack of input that you're getting once you've lost your hearing, and therefore you're hearing fewer words and fewer sounds, and then your brain just has to process a lot less. But on top of that, when your friends and caregivers, spouses are speaking to you, you'll get more confused because you're just not picking up, compounded by the masks, which make it, most people with some hearing loss, if it's gradual, they do learn to lip read to some extent, and then you've taken that away. And a lot of times the hearing aids, they don't work very well. I mean, I have patients who go through many, actually not advertising for this, but I'll mention that the new, the iPod, the Apple EarPods, they have like now a memory and hearing enhancement feature, and they're a lot cheaper and seem to work pretty well for people. But there's also something called a pocket talker, which is kind of like a Walkman. Thankfully, most of you actually know what that is, with an actual set of headphones, and you can just walk around with that if you're hearing impaired and have people speak into it, and it works really well, and it just looks like you're listening to music and never threw away your Walkman. So it's really important, and all the time I see a patient who's just sitting there kind of looking around, looking like they don't understand what we're discussing, and you put the pocket talker on, and all of a sudden the person's very engaged in what's going on. We don't have much evidence that it's a marker of memory loss. There are very few. There's like Susak's syndrome. There's a couple of very rare neurological syndromes where hearing impairment is part of the disease. But a lot of people with memory loss and et cetera have great hearing.
Thank you. So sort of moving along, I guess, in terms of thinking about, so that's a lot of the life, and we could obviously talk about lifestyle interventions for a long time, and those are things I talk about with my younger patients all the time. Pretty much alcohol is a little bit of fun, but there's no amount that's really good for you. Pescatarian, Mediterranean diet, try to exercise, weight-bearing exercise, and sleep. Those are all, key things that if people can institute those, whenever they can, but earlier the better. But beyond that, there's also obviously a significant sort of genetic component to a lot of this. And I guess there is some testing, there's a lot obviously now about the ApoE genetic testing, and are there people that should be running out and getting tested at an earlier age or at a later age, and when is it appropriate to test, and how much of that play, how helpful?
So we are not at the A1C for diabetes level of screening for memory loss in primary care quite yet. And the reason is probably money, because when the diagnostics companies that have developed these tests that look for basically Alzheimer's type proteins in your blood that are now available, like the PTAU 217 test and the Lumipulse, they're with some ratios of amyloid beta. They only studied them in patients who already had mild cognitive impairment, which means that if you don't have enough of a level where you actually start missing points on the testing that the neurologist, geriatrician, primary gives you, you wouldn't have even qualified to get that test. So in patients who already have the cognitive decline, They're very sensitive for picking up only very specifically early stages of a protein that's associated with Alzheimer's disease, about 86 to 90% sensitive. So like great tests, but with those massive caveats. So if a person comes in and says, hey, you know, my mom, she had Alzheimer's starting in her mid 80s, I'm in my 60s, but I don't have any cognitive issues really, I say, it's not worth it to get this test because number one, we have no idea how it would perform. And number two, yes, you can get these proteins glomming up your brain and spilling over into your blood before you get cognitive symptoms, but we don't know how much earlier and probably not this much earlier. What would we even do with that test? Because we actually don't have any medicines to treat somebody who does not have any cognitive decline. The medicines that Dr. McElhone has mentioned that slow down, they're only approved for people who already have demonstrated cognitive decline. So you probably would cause yourself more stress than benefit by getting that test, and it wouldn't be covered by insurance and probably doesn't need to be done. But that's my projection is that will change, and the companies will realize that they could just screen everybody. And also these markers, especially the p-tau 217, can be monitored over time. So I have made actually a massive shift in my own practice in the last half a year. Now that my patients, these tests for people with cognitive impairment are being covered, if I think it's due to Alzheimer's in particular, I will actually get the test because it's a number I can follow. Whereas the brain scans, even the amyloid PETs, much harder to follow. And so the data has shown you can follow that over time. And in that way, it's a little bit like an A1C over time.
That's interesting. Do you find that when you're following those levels, does it seem to correlate with any sort of clinical, like you're looking, like with an A1C? So an A1C is a 3-month marker of your blood sugar control, basically. So as opposed to we check your blood sugar, that's just a snapshot of what it is right then. But we really want to know, well, what does it sort of run over a longer period of time? So with an A1C, if your A1C is elevated, we know that, your diabetes is not being managed well enough, and so we need to add a medication. And that isn't, sometimes if somebody's really poorly controlled, we'll know that clinically, but a lot of times we don't. We just have to check the test, and because we're trying to prevent things from happening, we react to it. So I guess the question is, with these kinds of numbers, do you see, well, their beta tau, numbers went way up, and, surely enough that, there's more cognitive decline that's been present over the last year, or their cognitive decline seems to have slowed and their levels are the same or have gone down?
It's a mixed bag, but this goes back to the fact that, number one, we're here to talk about memory and other types of cognition. And like in almost all conferences these days, we're spending a lot of time talking about only Alzheimer's, right? And not microvascular or vascular disease of the brain or alcohol related or other types of neurodegenerative conditions, traumatic brain injury, et cetera. But in Alzheimer's, these tests, these protein level tests, they're not genetic, they're protein level tests. They're all measuring one protein that over about 100 years, neuropathologists have figured out is associated with people who also have this described condition of Alzheimer's disease, which only 50% of the time is memory predominant, where it's like the short-term memory is the biggest issue, but other times it's language is the biggest issue, visuospatial function, executive function, praxis. So when the person has a condition, it's hard to know, and they have this protein, there's about and the person has no symptoms, there's about a 75% chance that they will go on to develop the stages of Alzheimer's disease. But it's not 100%. Okay? So there are some people out there walking around with brains full of amyloid plaques and no symptoms, and they're in their 70s, and we don't know why, and they're followed for decades and nothing develops. So we think we only know about 50%, rough number, of why Alzheimer's develops, why the symptoms develop. There's another protein called tau, T-A-U, which is much more closely associated with cognitive losses. We don't have a specific blood test for that. I know that the blood test I told you is called p-tau. It's more closely associated with the amyloid plaque. This second protein, we don't have a specific treatment for it yet. None of the infusion therapies directly target it, but we're going to get there, I think. So that's a second protein. a lot of people, including myself, think brain inflammation and different factors that could be targeted that also contribute. So I think an A1C is a lot better than where we are with the protein Alzheimer's tests, but it is, I think the goal is that eventually probably it's going to be a whole bag of tests, like 3 or 4 things that we send and we follow, especially because the disease is so heterogeneous. Like we have patients who have a much stronger genetic version who will have symptoms and really decline in their 50s or their 60s. And unfortunately, patients with or without these known genetic mutations, it often goes a lot faster. We also have patients in their 90s who have a brain full of amyloid, but no one would ever say they had more than normal aging. So it's not, the research is not quite there yet to give us the clarity that diabetes has.
So to just maybe go backtrack or shift gears a little bit, just from the perspective of like geriatrics or management, people come in mild cognitive impairment or falling more under the dementia category. What and thinking about, I guess, in the context of the Pointer study too, or maybe not even in that context, like what do you do? Like it's a very multidisciplinary field that involves a lot of areas of intervention. How do you guys how do you approach that, or how do you?
So for somebody that comes in with memory loss, I do comprehensive geriatric assessment. My visits take minimum of 90 minutes. Sometimes longer, which shocks people because they get maybe 15 minutes with their GP. But we look at, all of these areas. We do a full history. We want to know what their education background is, what the family medical history is. We go over all of their medical problems in excruciating detail sometimes. Social history is important. What was their smoking? What was the alcohol? Are they doing those things now? Was there any drug use? Because sometimes my geriatric patients have had good times in the past, sometimes currently, but we want to know about head trauma, concussions. I had a football player that came in not too long ago. He had a lot of concussions when he played in college. So we take a very comprehensive history. Our exam's pretty thorough. We do look at, sensory function. We look at the, neurologically, we look at gait. We do, in-office testing of cognition. The 2 tests that I typically do is the Mini-Mental and the Montreal Cognitive Assessment. It just gives me a nice little picture of what's going on, and we do depression and anxiety screening as well. We sort of make a plan from there, depending on, what my assessment is. And, the clinical history is still very important for me. And primarily an Alzheimer's process is going to present differently than primarily a vascular process or a stroke-related process, which is going to present differently than a Lewy body or Parkinson's process, which will present differently than frontotemporal process or the other ones. So we got to really, this whole big picture gives me a strong idea of what is going on. If there is a cognitive problem going on, first of all, or if I think maybe, sometimes people come in and there's just super high anxiety, or there's something, a mood disorder, or maybe all of the above, maybe there's something else going on. A lot of times from there, if my assessment if I'm not entirely sure, or if I think that there's enough of a mood problem that I'm concerned, or if maybe they're super high functioning and I'm not catching anything on the cognitive, on my office cognitive test, I will refer them for something called neuropsychological testing. And that is a very comprehensive test done by a specialized psychologist where they're looking at all of the cognitive areas of the brain. They're getting an extensive history. They're getting an idea of what this person's baseline function is, and then based on that, we can get a very closer idea of what's going on with this patient. I will also do, neuroimaging as part of my evaluation. It's it's pretty thorough. So, and people are usually back a few times before, I have a really, 100% understanding, or maybe 100% isn't even right. Maybe it's 75% understanding what's going on. Anyway, that's my.
Yeah, from my perspective, I went into neurology and diagnostic / comprehensive neurology because I like going into rooms and not knowing what's going on, and trying to figure it out. I like to formulate a diagnosis and a treatment plan, prognosis. So I like undeclared sorts of cases. And for me, the biggest worry is, what is it if it's not Alzheimer's? So, for example, I had a patient come in 2 weeks ago, 58 years old, with delusions and short-term memory impairment, nothing else on their history or exam. And I'm so worried that, is this early Alzheimer's disease, or am I missing something where I have to do a much more comprehensive workup, including lumbar puncture and a lot more, autoimmune encephalitis is another, so I like to get to once I get to the diagnosis, I can breathe a sigh of relief, actually. So sometimes I think I precipitate an Alzheimer's disease assessment to just get to a diagnosis. So I don't have to do all of the other things that would go with an alternative diagnosis, for example, in this younger woman who I'm really worried about.
I tend to try to find everything that I can do to improve overall cognitive function, regardless of what the diagnosis will be, because contrary to how I was trained at this point, it's the biomarkers. Ever since 2018, it's just the bloods, the spinal fluids, and the brain scan that dictate if I'm going to say to the person in front of me, you have Alzheimer's disease or you don't. And I could be saying that to someone with zero cognitive impairment that somehow maybe through research got all their biomarkers done, or someone with severe where it's very clear. So regardless of that, and because of everything we've just said for the past hour, that even once you get that diagnosis and that process is happening, I treat it as a chronic disease. Maybe because I see so much of it, how could it not be? I can't be devastated every single patient visit. So for me, it's a chronic disease, and I say, if you had high cholesterol, it's a risk factor. You would just have to live with it and deal with it, and it would be silent, and you wouldn't know. And this is, in a lot of ways, the same thing. So we just have to look for anything that could worsen it and speed it up. So I'm kind of doing two things concurrently. One is trying to figure out, is this person, what kind of progressive, if it's progressive memory issue, does the person have? And then trying to fix anything that could be going on. And most common interventions, I would say, I've mentioned the sleep checks. Which would be like a sleep study. Usually insurance covers an in-lab test only if you've had a home sleep test, but please don't ignore your doctor if they've asked you to go get one. Then we do, I'll counsel on things like alcohol and cigarettes. We will often look for vascular reasons, and you can have both. We do know that having strokes and vascular disease of the brain can hasten neurodegenerative, like progressive memory disorders as well. So preventing future strokes, maybe being on medications like an aspirin or a Plavix, to start them, because on the flip side, you could be a person more prone to brain bleeds, and that could make you worse. But looking at the data and looking at the scans and the ultrasounds, maybe the person's also having seizures, and you want to make sure that actually it's something like up to 50% of patients with Alzheimer's may have had seizure. It's like wildly undiagnosed. So that's something that I don't always check for seizures with an EEG, but if there's anything where I'm suspicious, might look for that. But also all the primary care things. And this is why I'm always running behind. Sorry if you ever come see me, bring a newspaper or a book. Things will come up at the last minute, like, oh, look, there was anemia for a long time. Well, that causes fatigue. And if there's a significant anemia, or even a low vitamin D, like below 20, or a low vitamin B12, or some kidney dysfunction, even from dehydration, you're going to be tired. And when you're tired, or if you've just had an infection, you don't pay attention. And when you don't pay attention and your brain is foggy, then you don't learn, and you certainly then don't retain. And all of that, whether or not you have an underlying process that actually affects those functions, makes you worse. And I've learned this because I also have patients coming to me like 18 and up for other brain fog related conditions. You see these wild reports, from one recently from China about a 19-year-old getting diagnosed with Alzheimer's. Jury's still out if that is validated, but and they say, oh, could I have this? And I say, no, you have like regular human being cognitive fluctuation, because you're not exercising, because your sleep cycle is totally dysregulated, you're out partying, and then you expect to be totally alert the next day, for your testing, or you suffer from sleep apnea and you're 39. And I had a patient who was on disability and got back to work when he treated his sleep apnea. So, you have to be alert, you have to be awake, you have to have not just not too high blood pressure, you also have to have not too low blood pressure. I'm speaking to you, the petite women out there in the audience. Every time I have to give a quote about the risks of hypertension, I always try to get the journalists to talk about hypotension too, and they never do. I guess it's just too complicated to tell people. But if your blood pressure is running the top number below like hundreds, or if you get faint when you stand up. I was at the gym recently, and the teacher said, "Oh, well, when you stand up, you might feel a little woozy. That's normal." And I said, "No, that's not normal. That shouldn't be okay. That could be a problem, and that could be starving your brain of enough blood flow. Or you could have depression, and you just need that treated so that you're more alert and focused." So we're looking for everything else we can do while using the advancements in Alzheimer's research and getting people into clinical trials as well. And I will take 1 second to make a plug for one clinical trial that we have at Weill Cornell that I'm doing, which is for mild cognitive impairment and mild dementia only. So it's a person who's still somewhat functional and able to eat on their own, or not even needing help around the house, and has a likely diagnosis of Alzheimer's, and has either been on those infusion therapies we're going to get to, or doesn't want to do the infusion therapies because they have their own risks, and wants to take the equivalent of a type of vitamin supplement for 13 months and come into our office. So that's an NIH-sponsored study. It's called the BENFO trial, so we are doing that. And we try to, I think a lot of times my colleagues refer patients up to Yale, who has a great memory center. Try to get involved in trials if you have the time and energy for it, because you might be in the placebo arm, but you're going to learn a lot. You're going to get some testing back on yourself, and you might even just be more motivated to fixate on your health and do all the healthy things while you're in these trials. And that's how new drugs come about.
Absolutely. Like the Yale Alzheimer's Disease Research Center, they have ongoing clinical trials, and you don't have to have any kind of cognitive impairment. So if you're interested at all, I would look into that. And one thing I forgot to mention is medications. Medications can be hugely problematic for brain function. Probably top of the list is the anxiety medicines, the benzodiazepines, things like Valium and lorazepam, but also medications that we might not think about as contributing or making us, contributing to cognitive dysfunction. Things like medicines for our bladder, for urge or overactive bladder. Antihistamines that we might use, especially, and there's tons of over-the-counter medicines. I have people that take Tylenol with, you're mentioning the opiates, which is another one, but Tylenol PM. Tylenol PM has diphenhydramine in it. It's an older anticholinergic. Not particularly good for our brains, as well as can cause constipation and dry mouth and all that stuff. So there's a number of medicines. So we go in detail in the med list, and so medicines are potentially problematic for our patients too. There's a list that us geriatricians and other doctors use. It's called the Beers list, that has. And it's developed by the American Geriatrics Association. A panel looks at all the medicines that are prescribed and there are certain medicines that are on the please don't prescribe list, and we look at that list when we're looking into prescribing or deprescribing. So if you have any interest, check it out, Beers list. BEERS, just like a beer.
Don't drink, but check the beers list. Okay. So I guess that sort of brings us into the realm of kind of newer therapeutics, newer clinical trials, or more recent things. You mentioned the infusions. Do all of you or any of you have, experience with, Leqembi or other infusions, and what is that experience, and is it successful, or what, who should be thinking about those things?
So when you come to a memory center and you think, or the doctor thinks that there is a progressive condition, then they're going to try to figure out what kind. And there are some pills that you may be offered, whether they're on label for Alzheimer's disease or off label, maybe for microvascular disease, or because they're not sure exactly what kind of neurodegeneration, but they can see that in your markers. But that was the status quo a few years ago. And in the last few years, finally, the FDA has approved two, actually it was three, but really it's two that are safe and useful, infusion therapies. And they're interesting because they work a lot like many monoclonal antibodies that people are getting for all kinds of things. And so there's more acceptance. And these are infusions of liquid into your vein. You go to an infusion center, you sit there for an hour, and they're either once every 2 weeks or once every month. And they're not miracle drugs, but they can slow the progression if it's clear that there's Alzheimer's disease, usually on a spinal fluid test or an amyloid PET scan. The blood tests aren't really, we try not to use those as the only proof. Those medications, so we're using donanemab, which is also known as Kisunla, and lecanemab, which is known as Leqembi. A lot of people come in and their first question is, can I get this? And I say, whoa, we have no idea if you even have Alzheimer's. Why is it so important to know? Because the medications are extremely specific. They're not a global immunosuppressant. They target that one protein, that amyloid that I mentioned earlier that's associated with Alzheimer's disease. They just go after and they neutralize that amyloid. And they suck it out, and then they get your brain to clear it out in the glymphatic system. They, to some extent, maybe so they clear out between 60 to 80% of the amyloid. Lecanemab's more 60 to 70, donanemab's more 70 to 80. You'd think, well, that's a great number. Like, how come Alzheimer's doesn't stop? I mean, they don't give you back your neurons, but how come you don't stop it dead in its tracks? Well, that's how we know that amyloid isn't the only thing causing Alzheimer's disease. Because even for patients where you clear out all of it after a year or a year and a half on therapy, they will have slowed, most of them, their cognitive decline, but not by that much. The slowing is somewhere around 27 to 30% with lecanemab, and maybe up to 35% in some groups in donanemab. The two molecules target just a different conformation of the amyloid. The donanemab targets the amyloid that's a little bit more formed into actual plaques. But the reality is it's not a miracle drug. So, well, why don't we just give it to everybody? Because it has a lot of side effects. And we are hoping that other things come out in the next few years that have fewer side effects, because these drugs can cause brain bleeds in about roughly 1 out of every 4 patients. So it's significant, and they can cause brain inflammation, and we do see it in clinic, and there were deaths reported in the trials. There are risk factors that patients have to have in order for us to be more worried, and some people can't get the drug, even if they meet all the other criteria. We talked a little bit about testing, and you'd mentioned APOE. It's a genetic test. That test I would not recommend everybody just get for the sake of it. That test, it's a genetic test, but it's not like, those breast cancer genes, BRCA1, 2, and if you have it, then you're going to get breast cancer. They're not like that. Even if you have the worst kind, which only 2% of the population has, the ApoE, 2 copies of E4, the two copies of the gene, the 2 alleles, you by the time you're in your 80s, you're going to have a 50 to 60% chance of developing Alzheimer's disease. And that doesn't mean you'll even have dementia, but you'll have some of that protein. But it usually causes more worry than benefit just to get the gene. And we certainly won't treat anybody just based on the gene. But where it has come in handy is if you have that E4, you're much more likely to have brain bleeds. Why? Because together with Alzheimer's, what a lot of people get is that amyloid plaque in their blood vessels of their brain. And that's a related condition called cerebral amyloid angiopathy. We call it CAA. You may have seen an article about it. A lot of patients with Alzheimer's get it. It's just the amyloid right next to the brain tissue itself in the blood vessel. But like a brick wall, if you remove one of the bricks, and because you've gone in and you've got this powerful anti-amyloid therapy and you've removed that brick that has amyloid on it, you're going to leak. So those patients have a much higher risk of bleeding. We think that's why. And we try not to ever give these medications. There have been a few exceptions, but generally we try never to give because the risk is just too high and the benefit is not really there. But that may change. And then if you have 1 copy, you're at slightly elevated risk, 1 copy of the E4. If you're on a blood thinner, you have slightly elevated risk. If you have unstable other disease, like if you have unstable heart disease or kidney disease, liver disease, we don't want to rock the boat there. We want to wait. If you're on chemotherapy, typically you have to wait until you're done. So there are things that exclude, but we still do a lot of these infusions. We still refer our patients for these. And I was just speaking with the other 2 dementia neurologists that I work with in our practice at Weill Cornell. And anecdotally, over the last 3 years, we do feel like, in general, our patients who are on these drugs seem to be progressing a little less quickly, that their disease is not going down as quickly as we're used to seeing. And that kind of fits with what the data shows. The big caveat that these are all company-sponsored trials who really handpicked all their patients in them. The government, hasn't actually sponsored any of these trials on the whole, so probably a lot we don't know. But I think if you're a candidate for it, you're probably right whether or not you choose to do it. But do know that there are a lot of people who, if they are lower risk, are on these therapies. I have some who have graduated to maintenance therapy at this point and are doing pretty well.
So that covers a lot of ground here, I think. I mean, the other things, we have a question sheet that circulated around, and one of them is about the EVOKE trials, which are using one of the GLP-1 medications to, target metabolic health in Alzheimer's. And I think those are mostly ongoing studies. I don't know if there are results that you guys have seen as of yet or anything.
Looked like it. Yeah, I looked at.
Yeah, the EVOKE trial so all these are the weight loss drugs. It's that whole class. It's Wegovy, it's Ozempic, and right now there are many indications that are not covered, but people who have, I think it's now diabetes, right, and sleep apnea, I think, is becoming a
people
way
get
to
covered
get
for that?
Yeah.
So diabetes, definitely people
Yeah.
get covered for. Once in a while, people who are like obese or morbidly obese will be covered.
Yep.
There's a ton of other indications for them, like sleep apnea and cessation of alcohol, but those things are not. They never get covered.
Yep.
So they're not easy to get covered.
They're not easy.
Yeah, and they're expensive.
So this is a tricky one, but you should know about it because it's going to be in the news a lot next year and already has been. So in speaking with Novo Nordisk, I can't get any info out of them. They won't tell me like how the EVOKE trial is doing, and I keep poking and prodding, and that's good because they shouldn't. But the big question is, if you give somebody a drug that's going to improve the way that their body processes glucose, and that drug is also going to the brain, are you just helping their risk of progression of cognitive decline because you're helping them lose weight, you're helping them not have high cholesterol, et cetera, or are you independently helping the processes of their Alzheimer's, like their neurons to function better, to get better metabolic function because they're processing glucose better. And there are many other studies about insulin resistance and improving that in the brain. So the hypothesis is interesting, but in reality, what you're talking about is if these get approved, then you'll have a person who's in perfect shape and has no medical conditions and now has to get prescribed this drug. Well, what if they lose too much weight? What if they get sick from it and have terrible GI illness from these drugs? Is there really a benefit? And the theory behind this drug is it's somehow helping the brain to process the sugar and it's decreasing brain inflammation. The evidence is pretty sparse up to now. They took a study from 2020, repurposed the data, reevaluated the data from a type of brain scan that looked at brain metabolism and said, oh, look, actually, this is actually pretty effective. And that's what they used to get enough data to say, we're going to run this big trial on this. But there are some really brilliant people who work at these pharmaceutical companies. So it may become available next year for Alzheimer's disease. And that doesn't mean it's specific to Alzheimer's disease. That means it's good for probably anything that helps the neurons to survive. So if it gets approved, it might be something we end up using off-label for other neurodegenerative and other memory conditions as well. And if it doesn't, I'm sure there will be more trials looking into it to see, are there ways to optimize it, deliver it better to the brain, so that they can get approved, because there are big companies behind it.
I was going to, we've got about 13 minutes left. I was going to maybe open it up to the floor for questions. Anybody? Yeah.
Thanks, Heather. Sorry. And his presentation was about the research they're doing with L-serine and the implications of kind of taking or ingesting that chemical and how that might reduce the buildup in your brain, linking or causing or associated with Alzheimer's. And he also had looked at other studies on some island, not Guam, but some South Pacific island, where a chemical in some fruit that was eaten by monkeys, that was eaten by people, wound up causing Alzheimer's, and they came up with that direct link. And my question is, all of this is still in, all of their research is still in research mode. Nothing is approved. And I was just curious if you have heard about this, if you have an opinion on it, if you're maybe not allowed to because it's not approved. But it seemed, I was intrigued by the research they were doing and kind of what he had to say, because it sounded different than a lot of everything else that we've heard out there.
All I can say is, like, I looked into the L-serine thing and I found myself going down a rabbit hole and found nothing to support its use. That was me. And I get the question a lot about like nutraceuticals, right? I mean, we have a very robust like nutraceutical and companies that are pushing products on, I think, a population that wants like an easy fix, to take just a supplement. And I don't think that there's not been anything I mean that I've seen that can slow down cognitive decline that's in the nutraceutical aspect, unless you have like a B12 deficiency or there's something that you are deficient in.
Yeah, there's one study last year, I think, out of Colombia that looked at a multivitamin just for the general community population, and they ended the study early because they saw a benefit in cognitive scores for patients who just started taking a multivitamin. My suspicion is there are just many people who somehow are a little bit deficient in their diets, just aren't getting every single thing that they could be. Part of that might be more the B complex vitamins. It might be the vitamin D. These cognitive scores, they again could be a measure of fatigue, attention, brain fog, those sorts of things that could come from having some nutrient deficiencies. When it comes to specific substances, L-serine is one. Recently, we get questions about lithium or orotate because that was the Harvard small series that was published. We talk about this all the time in our own meetings at Weill Cornell. We have hundreds of these substances, chemicals, and even like as younger doctors, we were all intrigued and we'd go work in the lab and work with the mice and see, does it help the mice to run faster through their cage? And, there are a lot of substances that work well in a cell plate and help mice to some degree and did not meet endpoints for being useful in human beings. And so we have nothing that we can say, well, this is, if all your tests are normal, you should take this. That said, when you eat a very clean diet full of not just omega-3s, but, you could take those too, but you're eating like the MIND diet, but specifically things like a lot of olive oil, avocados, nuts if your stomach can handle them, salmon. I carry sardines in my bag almost every day. My husband usually doesn't want to get anywhere close to me, but ever since I started reading these studies,
You carry sardines
they
in your
travel
bag?
really well. They never leak. She's moving away here. These things make a difference. I can't tell you that they're going to slow down the day that you start developing memory loss if you're predisposed to Alzheimer's, but they certainly will improve your general feeling of well-being, attention, alertness, maybe your mood. They'll help you learn better. They'll make you more present. This is for people with and without memory decline. So I think the nutraceuticals, they take it a step further because they're adding all these other substances. I will say a lot of them have caffeine in them. Like my mother sent me something after COVID. After I had COVID, she said, this is great. This is going to fix your brain. You're going to feel so much more clear. I looked at tons of caffeine in it. So, well, I've got this, so I think I'm okay. But, and caffeine is processed differently. Some patients don't do well with coffee, but do great with matcha or green tea extract. So if you're going to be pursuing that, and you have the budget for it, it's probably okay. There's a lot of studies on resveratrol, like the chocolate extract. That looks like maybe that's progressing a little faster in terms of the studies. But if you're keeping your diet really focused and you're doing the physical activity, you're probably giving yourself a lot of that naturally through foods. And most of these substances are absorbed better when they're absorbed naturally through foods than they are in a pill. It's a tough one, but probably in 5 years we'll have new things that we're
Hi, can one of you or more than one comment about Aricept? Good, bad, does nothing, used to be okay.
I don't have a particularly good opinion about Aricept. I mean, I think back in the day when it, like 25, it's been out for a long time. I think it was pushed, it was marketed that it slowed the progression of cognitive decline and dementia. It really, studies since then have not shown that, as a matter of fact. I call it, most of us call it a cognitive enhancer. I tell people it's kind of like taking Tylenol for arthritis. You will mask, or you potentially, I don't even want to say you will, but a small proportion of people might feel less pain, but it's not changing the arthritis at all. So that's my thought on donepezil.
How many of you are familiar with this Aricept or donepezil? Heard of it? Yeah, so the ones that are, it's been around for many decades, and it's the mainstay of a lot of memory care. A lot of primaries, with good reason, will just let you try it, see how you do. It can have many devastating side effects, but not usually irreversible unless they cause a low heart rate and and sometimes low blood pressure, and you fall and you hurt yourself. Other than that, and if you watch out, you stay hydrated, everything's reversible, but cause a lot of diarrhea, a lot of insomnia, weight loss, agitation, increased urination. That said, I do have patients every single week who come and say, Thank goodness. My mom, myself, my dad, so much better on the Aricept. Why? Because it gives back the one neurotransmitter to the brain that has been shown to be decreased in Alzheimer's and some other forms of progressive memory decline, including it can be off-label for vascular decline. Some people are just low in that choline in the brain, and it's like a Tylenol. It's like a coffee for your brain. It's just a very targeted supplement. It gives you back that choline. If you can handle the effects of it going into your gut, or you can get a patch version, it might kind of make you a little more alert. You might call your mom a few more times, or your siblings. You might answer where you are a little more often during the day. So I can't say I hate it, and I can't say I love it, but I will always try it. Same thing with another one called Namenda or Memantine. The only reason I'm mentioning these meds is because there are only two in memory care besides the antidepressants and stimulants and alertness drugs that we actually use routinely. We'll try them, and oftentimes off-label, because if they work, great, and if not, you get off of them. But the main thing is, like many diseases, you have to give yourself a chance to try things out. And just be very vigilant and know to stop, because if you just ignore, you might be missing out on some therapies that are useful.
My patients, I don't think, have a lot of side effects from the low-dose Aricept that I keep them on, and I don't know. Anecdotally, like you said, some folks have benefit. So
yeah, we think like 20 to 40% improvement in daily function, but no slowing in decline. That's the data.
Hi. Thank you for coming. All of you have provided very valuable information. I have a question regarding a sibling of mine who has dementia, and she's in assisted living. And I hear all the recommendations you're making about diet, exercise, and all these things, and she's really not getting any of that at assisted living. She's offered it, and she says no, and she just wants to sit. And this was a woman who was brilliant, outstanding in her career and everything. Do you have any suggestions if we have family members that we want to coax into healthier habits? Be all ears for that. Thank you.
I will say that their patients have autonomy, first of all. So like I can't force anybody to do anything, and especially as dementia progresses, I feel like there's, or as somebody, whether it's dementia or it's something else, it's as people are declining, I feel like everything is going to be risks and benefit. Like, will there be benefit to, that diet, or I think certain interventions, the benefit maybe goes down. I don't know what stage she's at, but, and it's not worth it, I would say. But I understand you as a family member want to do whatever you can. And I think that's like, you want to be positive and try to engage, but you just don't want to force, I think.
I agree. Once in a while, what you're dealing with is depression, which is part of the disease, not reactive to the disease. Or you're dealing with fatigue, tiredness, and there might be another medical condition, or you might never find one, in which case there are some medications that might improve the dopamine and the serotonin and the norepinephrine in the brain and make someone more interested in what's going on around them and more willing to participate. So it may not slow down the ability to remember what you just said, but it might make for a better quality of life. So that's something to discuss with her doctors there.
What's the difference between Aricept and Memantine?
Yeah, they're just drugs that target that give you back different neurotransmitters.
But identical, there's not much.
They're totally different, but they both just like supplement the brain's general function, but don't slow down the disease. And they have different sets of side effects.
And Memantine been around as long as Aricept?
Almost. Yeah.
Maybe it came out like
Yeah, a little bit after, yeah.
We got one more over here.
You said You said depression was part of the disease. Could you just give a little more color on that? I don't understand.
Sure. So as there is degeneration of the memories of the parts of the brain that control memory function and other parts of visuospatial, language, etc., there's also degeneration and there are changes in the parts that control emotion and emotional functioning. And motivation and interest in doing things. So oftentimes, actually, a late in life depression or anxiety may be the first symptom of some kind of memory problem or some kind of other brain problem. So treating that, first of all, it's really important for general functioning. And secondly, you might even help out the memory because they're more engaged. But it could be just part of the disease process overall. That's a fantastic question. Most of the drugs are not specific for like patients with and without Alzheimer's or other memory problems. But recently there are some stronger antipsychotic medications. Like if you have a family member it's none of you here, but it's someone who's like really agitated and really hard to control on some of the traditional medications. There's one, brexpiprazole, that's out that's just for agitation in Alzheimer's disease. And that's coming. But yeah, generally it's treated pretty similarly.
Can you repeat the question, please?
Oh, the question is about sundowning and why it happens. So that is basically where later in the day, and it doesn't necessarily have to be like when the sun goes down. It can start as early as 1 or 2 p.m. People will become more confused. Patients with, cognitive impairment and dementia may be more confused and have some behaviors as well frequently. They don't know if it's hormonal, and correct me if I'm wrong, but if it's hormonal, or if it's just like the change in light. I think there's been a lot of research on it, but I don't think anybody has an exact understanding, but it is extremely common.
Have you ever tried to keep a toddler up too late? So every night, the brain has to cleanse itself of the toxins that overstimulate the neurons. And one of the hypotheses is that this substance called glutamate, which is an omnipresent neurotransmitter in the brain, there gets to be too much of it and it overstimulates the brain. And so you need time, especially when you have any kind of memory issue, even like after a concussion, what do we say? We say try to sleep a lot when you're not up and about. You just need time for your brain to recover, and sleep is a time where everything changes and your brain waves change and you clear toxins faster from your brain, which is incredible. So you just need that time to reset. And some people, they can only do a few hours or half a day before those toxins start building up. And it might be because of hormonal, light changes, etc. Trying to keep a good sleep schedule. I guess your question is like, how do you prevent sundowning also, right? Trying to keep a strict sleep schedule, trying to keep people, more alert and give them the sunlight during the day. But also there are medicines that if a person's only getting agitated and really confused in the evening, that they can be given to try to stave it off.
That's all, sorry. But my Alzheimer's, I think it is very helpful if you can take a nap and avoid foods that are, a Mediterranean diet is really, really helpful. If you can do it, do it.
I had read something and it made sense. You were talking about diet, but the article was talking about, we think of hydrating for our bodies, but this article was saying how important it was for the brain to be hydrated. And I think I never quite really thought that, and I have trouble myself taking enough. And they say when you think you're thirsty, you should have already been, hydrating. I think a lot of us are in that same school that we don't hydrate enough.